Diana, let's take a few minutes to go over hypertension. You've seen several patients today with elevated blood pressure. Let's begin broadly. Why is hypertension so important in medicine?
Well, sir, raised blood pressure is actually the leading risk factor for death worldwide. It surpasses smoking, infectious diseases, and even poor sanitation in terms of attributable mortality.
Correct. It's a silent but devastating condition. Can you tell me which diseases are closely linked to hypertension?
Yes, it's a major contributor to atrial fibrillation, stroke, myocardial infarction, and end-stage kidney disease. It's also one of the most common reasons patients visit primary care doctors and receive lifelong medication.
That's right. Hypertension is extremely prevalent, affecting nearly one-third of the adult population globally. And this number keeps rising. What's more frustrating is that, despite effective therapies and widespread diagnostics, less than 50% of patients achieve their target blood pressure. Why do you think that is?
Probably a combination of poor adherence, suboptimal treatment escalation, and possibly lifestyle factors that aren't adequately addressed.
Exactly. It's multifactorial, social, behavioral, and sometimes medical inertia. Now, let's define hypertension clinically.
Hypertension is the persistent elevation of blood pressure in the systemic arterial circulation, typically diagnosed based on thresholds identified in large multicenter studies.
Good. However, we now appreciate that cardiovascular risk increases continuously with blood pressure. That's why there's a shift towards using lower thresholds and total cardiovascular risk assessments rather than fixed numbers alone. Let's move to clinical practice. What are the four key considerations when assessing a hypertensive patient?
What is the true blood pressure level? Is there an identifiable secondary cause? Does the blood pressure require lowering? Are there specific reasons to choose one treatment over another?
Well summarized. Hypertension is mostly asymptomatic, but do you recall any symptoms that might be associated?
Some patients may experience headaches, epistaxis, or dizziness, but in the absence of hypertensive emergencies, these aren't usually indications for treatment.
Correct. And ironically, the antihypertensives themselves may cause symptoms like postural hypotension. So, what should we focus on in the clinical history?
Symptoms suggestive of secondary hypertension. Lifestyle factors: weight, alcohol, drug use, smoking, exercise, stress. Family history: pregnancy status, medication adherence.
Good. Now let's talk about measuring BP, a surprisingly nuanced task. How should it be done?
Ideally, after 5 minutes of rest in a seated position, with the back supported, legs uncrossed, and the arm at heart level. The cuff should cover at least 80% of the upper arm.
Exactly. A common mistake is measuring without rest or using an inappropriate cuff size. Also, we start by measuring both arms. Why?
If there's a significant difference, usually more than 10 millimeters of mercury, we use the arm with the higher reading for subsequent measurements.
Excellent. What are the three methods of measuring blood pressure?
Office measurement, done in clinics, historically used in trials. Whitecoat effect is a limitation. Home measurement encourages patient involvement. Readings are often lower than office BP. Ambulatory BP monitoring, most accurate, especially for diagnosis, offers 24-hour profiling.
That's right. Ambulatory BP gives the best estimate of true BP, especially for identifying nocturnal hypertension and variable phenotypes like masked or white coat hypertension. Now, tell me, why is hypertension considered a disease of aging?
Because age-related arterial stiffening, or arteriosclerosis, causes blood pressure to rise with age. It's rare in children, and any young adult diagnosed with hypertension must be evaluated for secondary causes.
Good point. And don't forget the gender and ethnic disparities. Premenopausal women are relatively protected, but post-menopause, their risk equals men's. Hypertension is also more prevalent in Black African and African Caribbean populations and urbanized communities. Now, before we wrap up, what are the essential investigations you'd perform for a newly diagnosed hypertensive patient?
Out of office BP measurement, ideally ambulatory or home urinalysis for protein urea serum creatinine, an EGFR lipid profile, and fasting glucose ECG to assess for left ventricular hypertrophy, fundoscopy cardiovascular risk scoring.
Excellent. You've covered the fundamentals well. Hypertension may be asymptomatic, but its complications can be catastrophic. Early detection and tailored management are the keys to preventing long-term damage.